Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientists monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. Sarah Lisanby will present Combining Transcranial Magnetic Stimulation with Psychotherapy for Treating Depression and OCD. The Brain and Behavior Research Foundation funds the most innovative ideas in neuroscience and psychiatry to better understand the causes and develop new ways to treat brain and behavior disorders. These disorders include addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, post-traumatic stress, and schizophrenia. Since 1987, the Foundation has awarded more than $400 million to fund more than 5,700 grants to scientists around the world. 100% of all donor contributions for research are invested in our grants to scientists. I'm delighted to introduce Dr. Sarah Lisanby. Dr. Lisanby is Director of the Division of Translational Research at the National Institute of Mental Health. She was a Foundation 2010 Distinguished Investigator Grantee, a 2003 Independent Investigator Grantee, a 1996 Young Investigator Grantee, and the 2001 Clairmon Prize winner for exceptional clinical research. Today's webinar will begin with Dr. Lisanby's presentation. This will be followed by a question and answer period. To submit your questions, please use the Questions tab on the control panel on your screen. Feel free to submit your questions at any time. Following the presentation, I will ask as many questions in the time allotted. And now, I'm pleased to introduce Dr. Lisanby. Sarah, the floor is yours.
Thank you so much. It's such a pleasure to be joining you today, and I want to point out that the Brain and Behavior Foundation gave me my first grant as I was just starting out in this field. So it's really a special pleasure to join you and share some of the research that we've been doing about combining transcranial magnetic stimulation, or TMS, with psychotherapy for the treatment of depression and obsessive-compulsive disorder, or OCD. I'm going to start at the end with my take-home points. First of all, depression and obsessive-compulsive disorder can be serious and disabling conditions, and unfortunately, current treatments are not effective for everyone who suffers from these conditions. Transcranial magnetic stimulation, or TMS, is newly approved and available for the treatment of depression as well as obsessive-compulsive disorder. Research is demonstrating that the effects of TMS are state-dependent. That means it depends on what the brain is doing at the time that it's being stimulated. We can leverage the state dependency of TMS effects to enhance its efficacy. My presentation will be about how combining elements of psychotherapy during TMS delivery may improve outcomes by leveraging the state dependency of TMS effects on the brain. So let's begin with what we're here to talk about, which is major depression. Depression causes symptoms that can include depressed mood, altered appetite, either increase or decrease, thoughts of wanting to end your life, suicidal thoughts, fatigue, low energy, altered sleep patterns, loss of interest. Over 300 million people suffer from a combination of these symptoms across the world, according to the World Health Organization. But not everyone suffers in the same way. We know that there's significant individual differences, the heterogeneity in the way depression is expressed, and this calls for the need for more precise and individualized treatments so that we can select the treatment that will be most effective for each person. Treatment-resistant depression, or TRD, unfortunately is more common than we would like it to be. Unfortunately, the majority of people suffering from depression do not respond to their first-line treatment. The NIMH-sponsored STAR-D trial showed us that when people with depression are receiving their first antidepressant medication, just short of half of them will respond to it. Of those who don't respond, otherwise known as treatment-resistant depression, they're switched to a second medication, a third, and a fourth. And you can see that the likelihood of responding after you have TRD shows diminishing returns from switching medications. So clearly, effective alternatives are needed for the treatment of treatment-resistant depression. Among the treatments we have for depression, they include psychotherapy and various forms of psychotherapy. The specific one I'll be talking about today is cognitive behavioral therapy. We also have psychopharmacology, medications for treating depression, and now we have brain stimulation. Originally, electroconvulsive therapy, or ECT, was the first form of brain stimulation in psychiatry, but now we also have less invasive forms, such as Transcranial Magnetic Stimulation, or TMS, which uses magnetic fields to stimulate the brain. So let me explain a little bit about how TMS works. Here you see a TMS coil. Inside the coil are loops of copper wire through which we pulse high voltage electricity. That electricity forms a magnetic field surrounding the coil, shown in the red dotted line. That magnetic field passes through the scalp and skull as if they were transparent, as I show you on this figure. When they reach the brain, they induce a eddy current, which is a circular current of electricity, illustrated by the green dotted line. So you can see that you can do TMS in a non-invasive way. It's a non-invasive way of using magnetic fields to stimulate brain circuits. It can be done in an office-based setting, as shown here, and the latest technologies use image guidance to carefully personalize where exactly we place the coil on the head. It's neuromodulation because it modulates the activity of circuits in the brain, neural circuits, stimulating them and altering their activity after the stimulation ends. TMS has been a fantastic and exciting tool in the field of neuroscience, which allows us to test brain-behavior relationships. Understanding what parts of the brain control different types of behavior has advanced our mechanistic understanding of the brain basis of psychiatric disorders. And most excitingly, it's now a treatment tool that is available today clinically. It has been FDA cleared for the treatment of depression and OCD. Now, what does TMS offer relative to the other interventions that we have? You can see that from genes all the way up to the behavior and subjective experience, there are different levels at which we can engage the system. Specifically, pharmacology engages the system at the level of molecules and receptors. Psychosocial interventions like psychotherapy engage at the level of behavior, and TMS engages at the level of circuits, basically understanding the network of brain areas that work in concert to basically lead to the behaviors that we experience. And so they're complementary. And very excitingly, TMS is a way of translating what we learn about the circuitry underlying conditions, such as a depression circuit shown here. So each box represents a different region of the brain. And you see it's a distributed network. And we can then engage a part of that network using TMS in a targeted fashion. And that is what led to the first approval of TMS for the treatment of depression and more recently, obsessive-compulsive disorder. These are the results of the randomized controlled trial, which was sponsored by the TMS industry, that led to the FDA approval. In blue are the response rates of people receiving active TMS compared to sham or placebo in the gray. And you can see after 2 weeks, 4 weeks, and 6 weeks, those receiving the active TMS were showing a significantly increased response in their depression. These are the remission rates, meaning the depression responding to the point that it was completely gone. And at 6 weeks with active TMS, there was a significant increase in the number of people achieving remission from depression. We conducted, with NIH funding, a replication of this in a similar size sample with our patients mostly had treatment-resistant depression, meaning they had failed 1 to 2 medication trials in the current episode, and they had chronic depression. In most cases, the period of depression had lasted on the order of 1 to 2 years. And we found a significant increase in the response rate to active TMS compared to sham, and also remission rate higher with active TMS compared to sham. Now I'm going to focus on these numbers for a moment, because 15% response or remission rate is good for those 15% of people, but what about the rest of the people? We need effective treatments for everybody. And that's what's motivating our research, to optimize the dose of TMS in order to improve outcomes for all persons suffering from depression and OCD. Well, how do we do that? How do we optimize the dose? Let me first define what I mean by dose of brain stimulation. The first aspect of dose is space. And here is a photograph from the Hubble telescope just to illustrate what I mean by space. But in the TMS domain, what I really mean is the TMS coil, where it is placed on the head, its shape, its orientation. These aspects of the TMS coil itself control the spatial distribution of those little electrical eddy currents, the little green arrows that are being induced in your brain. We can control that by controlling the shape of the coil. The second aspect of dose is time. And here is a Salvador Dali with the persistence of memory to illustrate the concept of time. But in TMS, what I really mean by time is the rate of flow of electricity through that coil, its frequency, its train duration, the spacing between the trains. These are the temporal aspects of dosing that affect outcomes with TMS. The third aspect is context. And as shown here in the cartoon, the man talking to his cat never ever thinks outside of the box. Context matters, not only with kittens, but also in terms of how you do TMS. So the context of having a treatment that's administered by a clinician, or whether you are just at rest, or whether you're performing a cognitive task on a computer screen, whether you're taking medications at the time of the stimulation, all of these aspects affect how the TMS may impact you. And so when we think about TMS dose in space, time, and context, other words for that are the where, when, and how of brain stimulation. So let's talk about the first one, spatial targeting. Here's basically a cartoon of a TMS coil. The electric field induced in the brain by that coil is influenced by many aspects of your brain and head anatomy, specifically the shape of the coil, also the shape of the folding of the cortical surface, and so on. And so here we see an individual MRI, and we've highlighted here the electric field strength induced underneath the coil. And I'm going to remove the coil just so you can see that better. So here is a depiction of the electric field induced in the brain. You can see it's tracking along these cortical folds here, but also other remote areas can be stimulated depending on their orientation relative to the coil. Now, everyone's head and brain is shaped differently. So to be able to personalize spatial targeting, we need to use individual imaging to guide the coil placement and to inform the dosing. Here is the same TMS coil placement on a number of different individuals. So you can see that each person has a different spatial distribution of the field induced in the brain. This means that there's high variability across individuals. Our approach to control for that is to use individual imaging and electric field modeling so that we can understand how much current each person is actually experiencing. Research has shown that we can improve and personalize the targeting by using tools such as functional magnetic resonance imaging to basically create a map of the networks in the brain involved in particular brain responses, and then we can use those maps in the TMS suite. We can use neuronavigation software where we load the MRI into the neuronavigation software, and we can see in real time as we move the TMS coil around on the head, we can see where we are relative to her individual anatomy. So that's something about the spatial aspect of dosing. Now I'm going to move to the context and how the effects of TMS are state dependent. Let's take a very simple example, muscle tone. So let's say we're stimulating the area of your brain that controls movement in your finger. And so we're activating the cortical spinal tract, the network of neurons that go from the motor cortex down your spinal cord to the neuromuscular junction in your hand. And then we can record the muscle twitch, basically how strongly are we activating that circuit. If we do this with your hand at rest, we can measure a baseline amplitude. And then we ask you to tense the muscles of your hand. That's called facilitation. And when we do that, we facilitate the response. Basically, we get a bigger response from the TMS than we do at the resting state. Now, that's a very simple example, but state-dependent effects occur with other brain functions as well. For example, whether you're asleep or whether you're awake, and your level of alertness and attention during the stimulation. Specifically, in this study, TMS was given in people who were awake or asleep, and state was measured by using EEG, electroencephalography, to measure the brain waves. And by using the EEG to record the brain's response to the TMS, they were able to measure these phenomena called TMS-evoked potentials, which basically is a measure of the brain's response to the stimulation. The blue line shows the brain's response when the person is awake. The black line shows when they are in non-REM sleep, rapid eye movement, and the red line shows when they are in REM sleep, which is rapid eye movement sleep. So the brain's response to the TMS depends on which state they are in. This is a graphical depiction that shows you in the waking state, when you stimulate with TMS to this spot, which is the yellow crosshair, the activation spreads to different areas of the brain, whereas when you're asleep, it doesn't spread as much, and the degree of spread depends on what type of sleep you're in, non-REM sleep or REM sleep. Another example of how we can control brain state stimulation is by using instructions. It could be simple instructions. For example, back to our very simple example of the motor twitch, here is the amplitude of the motor response. So these are two different, it's a thumb muscle and a first digit muscle. And the instruction is given to the person. Don't contract your thumb, but imagine that you are contracting your thumb. And just thinking about moving your thumb, it facilitates your response to the TMS. So when TMS is given, now the motor response in the thumb, because you've been thinking about moving, is stronger. Another example of how we can modulate brain state during stimulation is the paradigm called paired pulse TMS. We give two pulses of TMS to that motor cortex. One is a conditioning pulse, the other is a test pulse. And depending on the spacing between the two, if they're close in time, we dampen the response to the TMS, and if they're further apart in time, we amplify it. We can use this to generate what's called a paired pulse curve. And so on the x-axis here is the number of milliseconds between the pulses, and on the y-axis is whether we're amplifying or inhibiting the response. You can see that when the pulses are close together, we inhibit the response. That's called intercortical inhibition. Whereas when the pulses are further apart, we facilitate the response. That's called intercortical facilitation. Another example of how we can control brain state during TMS is to use stimulation. In this case, electrical stimulation is given to the median nerve in the wrist, and the timing of that stimulation is timed so that that message arrives at the brain precisely when TMS is being given to the cortical region representing the nerve being stimulated. This is called paired associative stimulation, or PASS. When PASS is done, what it basically does is it strengthens the efficacy of the synapses within that corticospinal tract. So two inputs, which are S1 and S2, are arriving to that motor cortex in the brain at the same time, and that strengthens the response by a principle called Hebbian plasticity. Put in simpler terms, what fires together, wires together. You can extend that concept by putting two TMS coils on the brain at the same time. And then depending on which one you fire off first, you can get opposite effects. This is called two-coil paired associative stimulation. In this case, stimulation is being given to the frontal cortex, then to the parietal cortex, or vice versa, parietal cortex first and then frontal cortex. Depending on the order of these stimulations, you can either magnify the brain's response to the TMS in the red curve or dampen it down, getting a long-term depression type of effect. You can imagine then, by carefully and cleverly timing different inputs to the brain, we could help to rewire and restore the functioning within circuits within the brain. But what if the circuit that we're targeting, such as in the treatment of depression or OCD, is more complicated than we could possibly design multiple TMS coils to reach? That's where we turn to using cognitive tasks. Because one way of thinking of it is that the brain is smarter than we are. We don't know all the areas of the brain involved in performing cognitive tasks or in performing cognitive therapy, but we can ask the person to engage in the task while we stimulate and activate their own circuit. Here's a very simple task that we use. We show you a computer screen that has 6 letters on it, and that's the stimulus, and then there's a retention phase where the screen goes black, and we ask you to remember those letters. Then we give you a probe and ask you, was this letter in the list or not? We do this in the functional magnetic resonance imaging scanner, and we can acquire images of what circuits in your brain are active during each of these 3 phases of the task. So you can see that whether it's the stimulus, retention, or probe, different areas of the brain are active. We can then use this information to target the TMS using our neuronavigation so that we can stimulate precisely during specific times within that task in order to enhance the functioning of the circuit performing that task. This is a paradigm we've called cognitive paired associative stimulation, or CPAS. And we use the CPAS in order to activate her brain network that's involved in doing the task while we stimulate online. How might this work? Well, it's a concept called functional targeting. Let's imagine that each one of these cylinders represents a set of neurons that are resting, and only a subset of these neurons are involved in performing the task. We have the person engaged in the task so that only those neurons are activated, making them then more susceptible to being affected by the brain stimulation. We can't make the brain stimulation as focused as a single neuron, but we can use the task to activate only those neurons that are involved in the circuit and then give the TMS to them when they're primed. This represents a way of providing a functional focality to interventions that are less focal than we would like them to be. And so we've used this paradigm called cognitive paired associative stimulation to activate task-related circuits while we apply TMS and leverage this Hebbian plasticity, the spike time-dependent plasticity, to enhance the potency of TMS. We applied this in people who were undergoing sleep deprivation. Sleep deprivation impairs working memory, a form of memory. And we coupled the TMS while the subjects were performing the task. We used functional imaging to locate for each individual where we should stimulate. And what we found was that when people were getting the placebo treatment, their working memory performance degraded. They took longer to complete the task, which was an increase in reaction time. But those that were receiving active CPAS did not show that degradation. We currently have a study underway now in healthy aging, which also affects working memory, funded by the National Institute of Aging. We've translated the CPAS concept now as an investigational treatment for depression. It works like this. We use a cognitive behavioral therapy that is administered on a computer screen and facilitated by a therapist in the room in the TMS suite. Engaging in that therapy activates the circuits involved in the learning process during the therapy. We then apply the TMS to the individual neuronavigated circuit. We have the subjects do elements of the task in the MRI scanner so that we can locate for each person where we should optimally stimulate, and then stimulate them while they're receiving the therapy. We completed a pilot study of this experimental treatment in 5 people with treatment-resistant depression. They came in for a screening. We did the baseline MRI to identify their target. Then they received 4 weeks of daily simultaneous TMS with cognitive behavioral therapy. Afterwards, we assessed their depression response and we repeated the scanning. What we found in this open-label pilot study is that all 5 patients had a significant drop in their depression scores across time. Now, of course, this could be placebo response, so that's why we're currently conducting a placebo-controlled trial to verify this result. But a very exciting result we found in these pilot subjects was that we were able to enhance the activity in the circuit we were targeting. Shown here from before T1 to after TMS, which is T2, we were able to increase the activation in the right ventral medial prefrontal cortex, this frontal area here, during a specific aspect of the task, also in the right hippocampus. So not only did we see preliminary evidence that this might be helpful for depression, but we were able to verify that we engaged the network that we were targeting. So we have a new study underway doing concurrent TMS with cognitive therapy for depression. The goal of our study is to leverage the state dependency of TMS effects to enhance antidepressant efficacy. We want to make this treatment effective for each person who is suffering from depression and make it individualized to their individual circuits and needs. Our approach is to administer the cognitive therapy to activate the network at the same time as we apply the TMS to enhance network function. Here's the basic setup of the experiment. We start out with an MRI during which the subjects engage in an element of the cognitive behavioral therapy to identify their individual network so that we can target for each person where to place the TMS coil. Then they come into the treatment suite and we use the frameless stereotaxy neuronavigation, which is image guided based on their individual brains, to place the TMS coil on their individual target. And then we have them perform the therapy, therapist assisted, computer administered, while they receive each treatment session. Some of the possible outcomes of this paradigm, it's basically a multimodal intervention where we're coupling psychotherapy with brain stimulation. You might, in future studies, generalize it to also include the third arm of therapy, which is pharmacotherapy. And depending on the timing, whether we do this sequentially, which is the psychotherapy first and then the TMS, or simultaneously as we're doing in our current experiment, you can imagine 3 possible outcomes. One might be that there would be positive synergy, that the two treatments together would work better than either one on their own. They might be net neutral, or there might be a negative synergy. One might interfere with the other. In the study we're conducting right now, we're asking the question whether coupling simultaneous cognitive behavioral therapy with TMS might be a positive synergy in order to boost the efficacy of this treatment. So to summarize the study we have currently underway, this is a novel investigational multimodal treatment for depression, which is based on a theory regarding individualized optimization of where we stimulate. So we're trying to optimize the spatial aspect of dosing. And we're coupling that with concurrent behavioral intervention, targeting the same network that's being stimulated by the TMS. Our goal is to enhance the plasticity in the targeted circuit to improve depression outcomes. Now, it turns out that there's already a regulatory pathway for coupling cognitive behavioral therapy with brain stimulation for the treatment of obsessive-compulsive disorder. Last year, the FDA cleared simultaneous TMS with exposure and response prevention treatment for OCD. This is the study which was published in 2018. Patients received a deep form of TMS called DTMS to the medial prefrontal cortex and anterior cingulate. These are frontal regions of the brain that are involved in OCD circuits. They received the TMS stimulation immediately after their symptoms of OCD were provoked by triggering their obsessions and compulsions. And so this combination of a behavioral intervention with sequential TMS, the active treatment, which is in the black circles here, showed a significant reduction in OCD symptoms. This was measured by the Yale-Brown Obsessive-Compulsive Scale, or the Y-box. So the active TMS plus behavioral therapy showed improvement compared to sham in the white circles. Here you see the percent of responders in the sham group and the active group, so a significant increase in response. So this suggests to us that coupling the concept of multimodal intervention in which we couple brain stimulation with simultaneous or sequential therapy could lead to an effective treatment. And indeed, this was the case for OCD and became FDA approved last year. Other research is underway on different conditions. For example, post-traumatic stress disorder. This study paired the deep TMS coil applied to the medial prefrontal cortex immediately after exposure to trauma narratives. So individuals who've been exposed to trauma and have PTSD, the TMS was being given immediately after evoking that memory in order to block the reconsolidation of that trauma memory. From baseline to post-TMS, the baseline is the dark gray bars, the post-TMS and behavioral therapy is the lighter gray bars. Those that were receiving the TMS plus the trauma exposure, which I'm highlighting in the red box here, showed a significant reduction in their symptoms of PTSD measured by the CAPS score. And you see that was not seen in the sham or the comparison condition. Both the OCD and the PTSD study used the specific coil, which is called the DTMS coil, which is also FDA cleared for the treatment of depression. You see it's like a helmet and the head goes inside of it. It's a non-focal form of stimulation. But in these two cases, let's go back to the concept of functional localization. So in these two cases, a behavioral therapy, in the first case it was a behavioral therapy for OCD, in the second case behavioral therapy for PTSD. The theory is that the combination was able to achieve a functional localization of the site of action, so priming those circuits involved in PTSD or OCD while they were receiving the non-focal stimulation with the DTMS. And so when we think broadly about the concept of multimodal intervention development, we have our three forms of therapy in psychiatry today. We have psychosocial intervention, psychotherapies, we have pharmacotherapy, and we have neuromodulation. And so a frontier in thinking about how to personalize treatment is to really think about paradigms that span all of these so that we can promote positive synergies, so that we can tailor treatment protocols to address all of the needs that our patients may have. And the study that I just presented to you focuses on this particular synergy between psychosocial interventions and online brain stimulation. So let me go back to our take-home points. First of all, depression and OCD can be disabling, and currently available treatments, although they are effective for many, They are not effective for everyone with depression and OCD. Importantly, TMS is currently available today as a treatment for depression and OCD, and it has allowed us to translate what we've learned about the circuitry in the brain underlying these conditions into targeted circuit-based treatments that are complementary to our other treatment modalities, such as medications and psychosocial interventions. Research has shown us that the effects of TMS are state-dependent. What the brain is doing at the time it's stimulated determines what effect the stimulation will have on brain function. The latest research now is leveraging the state dependency of TMS effects so that we can combine elements of psychotherapy with online TMS to improve outcomes by leveraging the state dependency of TMS effects in ways that can be personalized and targeted to what each individual person needs. I would like to conclude by recognizing the members of the National Institute of Mental Health Non-Invasive Neuromodulation Unit who have joined me in this endeavor. And I would also like to, again, thank the Brain and Behavioral Foundation for giving me my first grant and getting me started in this field. And I would like to open it up for questions while showing this slide where if anyone here has additional questions or would like to learn more about the study I presented you or other work that we're doing, we would be delighted to hear from you. All of our studies are on clinicaltrials.gov. Our lead study coordinator on this study is Shannon Exley, and there is her email and phone number, and I am happy to open it up for questions.
Thank you, Sarah, for really an excellent presentation with a lot of information. The one question that I have is, what's the next steps? Where do you see this progressing? What do you see happening over the next couple of years in terms of being able to have more people respond to treatment?
Well, that's a very good question. And next steps, there are a number of them. Let me start with the hope, which is today a reality. Some of the tools that I presented today, such as Transcranial Magnetic Stimulation, those are clinically available. And the access to TMS has been growing across our country and in other countries so that people who are looking for alternatives when medications or psychotherapy don't work for them, they can access TMS today. And as the clinical utilization of TMS is accelerating, we are learning from the clinical application about what the real-world effects are of TMS. And as we learn about how effective TMS is in the real world, we can better identify where the gaps are. One of the things that I hear a lot from my clinical colleagues who are running TMS services, clinical services, is that they are already doing some of the things I described, which is they are already trying to couple not only medications, but also psychotherapy while they're giving the TMS. And that has been useful in learning about the feasibility and also identifying the need to have a comprehensive care plan that incorporates all of these modalities. At the same time that the clinical access is growing and clinical experience is growing, we need to fill in some scientific knowledge about mechanisms that can really allow us to precisely enhance the effectiveness and personalize these treatments. And so the next research steps are really about performing randomized controlled trials that provide us empirical evidence of whether these innovations, be they multimodal intervention development or image guidance, we need the evidence to know whether these approaches actually improve efficacy above and beyond the clinical standard of care. And as that evidence emerges from randomized controlled trials that are currently underway here at the NIMH Intramural Research Program and also at extramural locations where investigators across the country and other countries are examining this, then that evidence can begin to inform the next phase of clinical care. As people publish these results, especially those using already FDA available tools like TMS, the dissemination of that evidence-based care can be accelerated because clinicians can then be able to use that scientific evidence to inform the way they care for patients.
Very good overview for where we are, where we're going. With the current research and your current experience with this, a number of people asked, how long when people do respond to treatment, how long does that response last? Does there need to be ongoing treatment? What happens once somebody does respond to this approach?
That's such an important question, because we know from the natural history of depression that depression can be a long-term condition, that even after you recover from your first episode of depression, you are at risk for the depression coming back. It means that we do have to have effective relapse prevention strategies. In the case of medication, typically, if depression comes back after you've recovered, medications may need to be continued longer term to prevent the depression from coming back. Likewise, with psychotherapy, it can be important to continue that to prevent relapse. In the case of TMS, the same is true. So when people respond to TMS, it typically takes 4 to 6 weeks to achieve the initial response. But then after that, it is absolutely vital that people remain on a relapse prevention strategy to prevent the depression from coming back. That relapse prevention strategy in the studies that we've done is comprised of a combination of medications that the person continues, and you can taper off the TMS. So the FDA-cleared TMS treatment protocol is after you finish the first 4 to 6 weeks, you then have 3 treatments a week, and then 2 treatments a week, and then 1 treatment a week, and then you continue on medications to prevent relapse. We've studied how durable the antidepressant response to TMS is by having people come back over a period of 6 months after they recover. And we found that when we do use effective relapse prevention strategies, that the response to TMS can be long-term and can be durable. But I think it's very important for people to understand that it is vital to continue in treatment even when the depression goes away or the OCD symptoms improve, to prevent relapse.
So if somebody's listening right now and they're experiencing depression and they haven't had treatment before and they are now going to go for help, they're going to go for treatment, how do they figure out what's the best approach? Should they take medicine? Should they have talk therapy? Should they try TMS first? Where does the science stand right now to inform people as to what to do?
Well, I think there's no substitute for having a thorough clinical evaluation. So I would encourage, if a person has not had treatment before, they've not sought treatment before, they're experiencing some of the symptoms of depression that we talked about, like the loss of interest, the low mood, that they seek out a clinician and have a comprehensive evaluation. Because sometimes we discover that what might look like depression might be the sign of a medical condition that's treatable, like hypothyroidism. Maybe you need to have your thyroid hormones checked. You certainly should have a thorough medical evaluation to determine if there's something going on with you that needs to be addressed that's causing the depression symptoms. This can start by seeing a psychologist, a psychiatrist. Often people start with really their primary care providers to be able to address whether there's something medically going on, and then they may be referred to a behavioral health specialist if it looks like it is depression. Now, the behavioral health specialist can go through the different treatment options for mild or moderate cases of depression. Oftentimes, starting with psychotherapy and evidence-based psychotherapy can be effective and very safe. And so that's where many people start. Now, sometimes if the depression does not respond initially to psychotherapy, or if it might be a little more severe, maybe the depression is already interfering with the person's ability to work or take care of their families and function, so on, taking a medication may be a very important step to be able to have effective treatment for depression. Now, when does TMS come into play? TMS is currently recommended after a person has tried an antidepressant medication and the medication was not effective. Often in practice, a person has tried 1, 2, 3, 4, or more medications before the time they get referred to TMS. So I think it's important for people to know that TMS is an option, it's available, and it is recommended as a consideration after a person has tried at least one medication.
So in the chart that you showed at the beginning, which I think was an important one about the STAR-D study, where for the first try, the first medication the good news is 50% of the people had a positive response. The bad news is 50% of the people didn't. Those people might be, that latter 50%, might be candidates for TMS at that point in time. And that's something they may want to consider.
Yes, that's exactly right. After the first medication fails, you would then fit the FDA criteria if you have a major depressive episode. Now, I should point out that TMS is currently FDA cleared for adults. And when you were asking before about what are next steps, we know that depression can start earlier in life. And it can be really tragic when an adolescent or a younger child has a serious depression. And in terms of next steps for research, it would be helpful to generate evidence of the safety and efficacy of TMS in younger people so that we can basically prevent the years of suffering that a person experiences when they grow up with depression and become a young adult with depression and so on. So I just wanted to clarify, depression is clinically available today for adults, and it's an area of very important research for the future to understand the safety and effectiveness of TMS in younger persons with depression, like adolescents or younger children.
So at this point, for an adolescent or a child with depression that may not respond to medicine and talk therapy, TMS is not an appropriate clinical option until there's more research done on that.
Well, I would say that it is not currently FDA approved. TMS is not currently FDA approved for adolescents or children, but this is an active area of study, and I think that there's hope and promise that research will teach us about whether and how TMS might be effective in younger persons. It is so important that we find treatments that are effective for younger people. Just like I showed you with the study where half of adults who get their first depression treatment don't respond to it. Likewise, the condition of treatment-resistant depression in adolescents and in children is particularly concerning and in need of development of effective treatment strategies.
I agree with you. That's such an important issue, and we don't think of this occurring in younger children and adolescents, but very important for people to be aware of. Another condition that affects all ages, including younger people, is anxiety. And I'm curious, has there been work with regards to TMS and anxiety?
So we and other groups have examined TMS in different forms of anxiety. I'm glad that you bring anxiety up because it is among our most common of the psychiatric disorders, whether we're talking about generalized anxiety disorder or whether we're talking about panic disorder or post-traumatic stress disorder. I mean, these conditions are common and can be very disabling. So we've conducted randomized controlled trials on TMS in the treatment of panic disorder, post-traumatic stress disorder, also generalized anxiety disorder when it's comorbid with depression, meaning the person has both conditions, the depression and anxiety. And some of those studies have been promising. I would say, though, it's not yet FDA approved for those conditions. But TMS today is being used in people who may have that combination of depression and anxiety. When I was talking about the heterogeneity of how depression manifests across individuals, it is very common to have symptoms of both depression and anxiety. And in the studies that we've conducted, we found promising results with the active stimulation faring better than the placebo stimulation in people with that combination of depression and anxiety. Now, there are variations in how we dose the TMS. So in the studies we've done, instead of using the depression treatment dose, which is stimulating on the left prefrontal cortex, we actually stimulate on the opposite side, on the right prefrontal cortex, and we used a lower frequency of stimulation, which is 1 pulse per second, or 1 hertz. And studies suggest that those lower frequencies have a different physiological effect on the circuits being targeted. So I would say that we have a lot of work to do to optimize the dose of TMS, not just for depression, but also and OCD, but also to optimize it for other conditions where it could show promise, such as in the area of anxiety disorders.
the very useful information again. Thank you. We have a question, and I think it's an important one, about the use of TMS in women who are pregnant, and I want to ask you about that.
So depression during pregnancy and in the peripartum period is such an important clinical challenge. When we think about how a person with depression, how it can affect their ability to access quality perinatal care, how depression during pregnancy can affect outcomes afterwards, postpartum depression, which women are at risk for, the hormonal changes around the time of pregnancy and immediately after pregnancy can lead to very serious forms of depression that can be life-threatening, literally, postpartum depression and postpartum psychosis. Now, the pregnancy period is one where we have to think about the risks and benefits of any treatment, of course. So specifically medications. When you're pregnant and you take a medication, many medications that we take cross the placenta and may affect the developing fetus. And we do know that some medications, when given during pregnancy, affect the development of the fetus and can have side effects not only for the mom, the expectant mom, but also for her future baby. And so there's been significant interest in using treatments that don't cross the placenta. Of course, psychotherapy doesn't. Psychotherapy is something that the mom can have, but it's not always effective. And medications can be used safely during pregnancy, but there's also an interest in having other things that don't cross the placenta, such as transcranial magnetic stimulation. So there have been studies in women who were expecting, receiving TMS, showing some promise. I would say that is not FDA cleared specifically for use in pregnancy, but I do know that within the medical practice, there are clinicians who have experience doing this, and there are research studies that have been done to evaluate the safety and effectiveness of using this in pregnancy. So I would say that it will be helpful to have more well-controlled studies looking specifically at the use of TMS during pregnancy to effectively treat depression and to prevent the really serious situation of postpartum depression, which can be really devastating for families and can impact these families during the time that they need the most support.
Very good information about this, and I just want to reiterate the importance of people who have just given birth and their loved ones to, if the new mother is depressed, they shouldn't suffer in silence. They should seek help. It's extremely important and treatable with appropriate care. Another type of depression that's important and affects many people is depression associated with bipolar disorder. And I'm curious about the use of TMS in the context of bipolar disorder and depression.
So thank you for bringing up bipolar disorder, which is another very serious condition. It is treatable. Unfortunately, the medications and the therapies we have are not effective for every person. And so bipolar disorder is also a condition where looking at new interventions such as TMS is important to do. We and others have done studies on using TMS to treat major depressive episodes in people with bipolar disorder. And the research to date does suggest that there is some promise in terms of antidepressant effects. We know that antidepressant medications that are developed for people with major depressive disorder also help depressive episodes in people with bipolar disorder. Same seems to be true for TMS. I will mention, though, a significant safety caveat, which is that depression treatments, when given to people with bipolar disorder, can induce mania, which is the other part of the bipolar condition. So episodes of mania can be quite serious, and just like antidepressants can cause mania, TMS has been reported to induce mania on certain occasions in people with bipolar disorder. And that's why when using TMS in the context of bipolar disorder, it's important that there is a mood stabilizer on board. So when we treat depression in bipolar disorder with medications, we typically use an antidepressant medication along with a mood stabilizer. Same is true when we've studied TMS in people with bipolar disorder, that we use a mood stabilizer in combination with the TMS so that we can achieve effective treatment of depression without inducing mania.
Very important point. So the concern about flipping into a manic episode with treatment with TMS is similar to the concern that we would have with antidepressant medication, to be very careful about that.
That's right.
Yeah. And another important condition, which often has significant depressive, anxiety, other symptoms, is borderline personality disorder. And I'd like to ask you a little bit about any work that's being done in that area.
So thank you for raising that, because we know that in borderline personality disorder, depression often can be come along with that, and so finding effective ways to treat depression in people with borderline personality is very important. We also know that within borderline personality itself, the condition can affect a person's ability to regulate their moods, and the more that we learn about how the brain circuitry that is effective in regulating mood and how it is affected in borderline personality could help to guide a way to use interventions like TMS for treatment of that condition. I would say that it's at early stages. In terms of using TMS to treat depression in people with other conditions that might include borderline personality, there has been some work in that area, but in terms of using TMS to target the ability to regulate emotion, that's at an earlier stage of development. But we have been involved in some work on that topic specifically. In fact, the Brain Behavior Foundation has supported Dr. Andrada Niescu at Duke University on a Young Investigator, NARSED Young Investigator Award. And in her study, she is coupling elements of dialectical behavioral therapy, so at psychotherapy, which is specifically designed to help with self-regulation in people with borderline personality disorder. And she's using these elements of the self-regulation skills that are part of DBT while the individuals are receiving transcranial magnetic stimulation in a way that is targeted to their individual circuitry. And so it's a study designed similar to what I showed you in terms of our depression treatment protocol, but she's developing this as a completely novel approach to try to enhance skill learning, DBT skill learning, for people who have difficulty regulating their emotion in the context of conditions like borderline personality disorder.
Thank you for bringing that up. All very promising. I want to ask a little bit about some of the logistics and sort of the nuts and bolts of this for someone who may be seeking TMS. How do you find the right place to go? And how do you know if you're going somewhere that they know what they're doing?
So that's a very important question, and it's similar to asking about how do you find the best place to get medication treatment or psychotherapy. Certainly a lot of people start on the web, and you see clinics that advertise, you see physicians or clinical programs that advertise, but I think it's important to be able to evaluate for yourself, is this a clinician I trust? Is this someone who I have confidence in? The access to TMS is increasing, so you will see direct-to-patient advertising for it. You'll hear it on the radio. You'll see ads for it, and so on. But ads are not typically the way that a person chooses a doctor. So it's useful to have a referral. And it's useful to ask the opinion of an expert. I frequently get calls or emails from people wanting to know who's a reputable TMS provider in my area. There are some professional societies that have websites. So, for example, there's a clinical TMS society that has a website that will help you find a provider who's a member of that society. And so there are networks that you can go through. There's also the National Network of Depression Centers that has within the network TMS providers. So there are ways of accessing that. But often it starts with asking your clinician, either your primary care provider or your behavioral health specialist for a referral and a recommendation.
Very useful information. One last question, and it's about one more very important diagnosis, which is chemical dependency, and especially in the context of the opiate epidemic and all the lives being lost with that. I'd like to ask you about TMS and chemical dependency.
Thank you for raising that. That is really such a public health crisis for us, and there are many different ways that work using TMS can contribute to helping us solve the problem of addiction and of overdose deaths. Now, let me start with the comorbidity between depression and chemical dependency and substance use disorders. We know that the two often go hand in hand, and finding treatments for that combination when a person is struggling with both conditions, depression and a chemical dependency, can be very important in being able to prevent overdose that might be coming from a wish to die or a suicidal overdose. Now, focusing specifically on chemical dependency, some people start using opiates because they've been prescribed them for the treatment of pain. And TMS can have a role in terms of developing treatments for pain that are not addictive. If we had effective treatments for pain that were different from opioids in that they weren't habit-forming, that they didn't lead to addiction, they didn't have that addiction potential, and that could not be abused and that you could not overdose on, that would really change the landscape, and it would help to take medications like opiates, reduce the amount that they're in circulation by replacing them with non-addictive alternatives. Research is underway right now, evaluating the effects of TMS on pain. There are studies that have been published, and there are studies that are underway showing promise. I would say it's not yet approved, but certainly research is heading in the direction of giving us answers about whether TMS could be effective in treating pain. Now let's talk about how TMS can teach us about the brain basis of chemical addiction. So TMS studies are underway and are currently being supported by the National Institute of Drug Abuse to examine how TMS can teach us about the brain circuitry underlying addiction. The more we know about that circuitry, the better we would be able to target it to directly treat conditions like opioid dependence or other chemical dependencies. And studies are currently being funded by the National Institute of Drug Abuse on that question. So I hope that answers your question. I would just, my bottom line is to say that the tools like what I've presented today offer promise. Some of them are available for treatment today, but they're also helping us discover how we can better treat other conditions in the future so that no one has to go without effective treatment for the mental illness or the chemical dependencies that they're experiencing.
Sarah, I want to thank you for joining us today and sharing all of this very important information, and thank you for the ongoing work that you're doing. It offers hope to people in the here and now, and also hope to people down the road. So thank you for all that you're doing.
And thank you.
Go ahead. Yes. I also want to thank everybody who joined us today. All of the research that we fund is made possible through private donations, so please consider making a gift by visiting bbrfoundation.org or call us at 1-800-829-8289. This webinar has been recorded. If you missed any portion of the presentation or would like to share it with family and friends, please visit the Events and Webinars page on our website. I hope you'll join us again next month when Dr. Camille Hoffman, Associate Professor in the Departments of Obstetrics and Gynecology and Psychiatry at the University of Colorado School of Medicine will present choline, a new prenatal supplement to improve a child's mental health. This webinar will take place on Tuesday, September 10th at 2 p.m. Eastern Time. Thank you again for joining us. Take care.